Good evening, everyone. Welcome to the first Virbac webinar of 2018. We've got 39 people logged in at the moment. I'm sure others will join us soon. I see most people are logged in with their full name. That's excellent. That makes it much easier to fill in your CPD certificates. If you have just logged in with your first name, it might be good to log out and then log back in again with your full name. It'll make it much easier to fill in the certificates. I see a lot of people have already worked out the chat. That's a great place to put any questions that you have for me or for Debbie. During Debbie's presentation, I'll write these down and we'll ask her to address them at the end of the presentation. At the bottom right-hand corner of the attendee list, you can also click on the smiley face, and that'll allow you to either put up your hand to say that you need to ask a question, or ask the presenter to speak more loudly or more softly. And when that no longer is relevant, you can clear your status after that. So that's a helpful little tool. I'll just do a quick little presentation and then I'll hand on to Debbie. We've got some polls during the presentation and then there's a quiz at the end, just 5 questions, and this will increase the CPD value of this presentation. It changes the type of CPD that this is and increases its value, gives you a different type of CPD certificate. So hopefully you'll hang around for that. There will be a recording of this presentation. We'll have that available on our Virbac Learning Centre along with all of the other webinars that we've got, and some learning modules are on there as well. So please do have a look at what we've got there. So as far as what we're going to do for our special focus on our ear medications for the first part of this year, we're doing a long focus this year for ears. It's going from the 12th of February through till the 25th of May. It's 3.5 months. So hopefully we'll get some good public awareness and give you a good opportunity to be able to make good use of these products. We've redeveloped some support material for you. So years ago, when Otics was first launched, we did have some plastic ear models that we had available. We don't have those available anymore, unfortunately. And while they do look very nice and the three-dimensional nature of them is very useful, they do take up a lot of space. It's difficult to have a lot of models available, and they do get dusty and need to be cleaned from time to time. So we're going to be distributing these ear diagram cards instead. So these are on some thick, heavy card. They're well laminated. They come A4 size, and so you can use this to demonstrate to your clients where the disease is, where the eardrum is, where you want the ointment to be deposited, where the cannula of the medication dispenser is going to go, where you want to apply ear cleaner, where to massage the ear canal to be able to distribute ointment and to help agitate ear cleaner. Because it's got a thick, heavy lamination on it, you could even draw on it with a whiteboard marker and clean that off afterwards. Just always make sure that it's not a vivid marker before you do that. We also have this otitis externa poster. I know a good number of you have a version of this poster already. It was just starting to look a little dated, so we've revamped it into the more modern style, bring it in line with the color scheme that we're using at the moment, but the information on it has been slightly updated in light of new information, but it's essentially the same. And this is a very good demonstration tool for talking to clients about ear disease, and it's something for clients to read through when you might be out of the room preparing your ear slides. So if you want either of those educational devices, please do talk to your area sales manager and we'll get those organised for you. We also have these Go Home pads. So this is an update of an already existing product as well. Just clarified the language a little bit, brought the style up to date. And so this is a double-sided A4 glossy sheet that you can write some information on about how they should be doing the treatment. And that comes in a pad of 50 sheets, so you can ask the area sales managers for that as well. So we've got those 3 support material items, which we're calling our educational material. As far as the incentive side of the promo, we've got 3 different levels to this. So we've got a special deal available through the wholesaler, starting from Monday, the 12th of February. Buy 9, get 1 free for both sizes of Epiotic, and buy 5 and get 1 free of Exotic. You do need to buy those all at once. You can't accumulate those over time, but hopefully that's going to be a manageable amount of product for you. We have a drawer for the clinics, so every bottle of Epiotic or Exotic that you purchase from the wholesalers puts you in the drawer to win from a prize pool of 2 wireless earbuds, 2 wireless headphones and 2 Bluetooth speakers, all good for your ears. And you don't need to do anything special. The wholesalers will send us their sales reports and we will be able to tell what you've purchased and how much you've purchased from that data, and put you in the prize pool at the end of that promo period. We're also running a second competition, so a 3rd layer of incentive, a competition for the owners. So there's another prize pool of 2 earbuds, 2 headphones and 2 speakers for clients to get. That's only for purchases of Epiotic. We don't want to incentivize purchasing of a restricted veterinary medicine to the public. They do need to enter the competition. There's no way of automatically entering them. So from your area sales manager, you'll be able to get wobblers or neck tags to put on the bottles that have the website that they need to go to. They enter the competition. They just need to keep hold of their proof of purchase, and we'll have them into the drawer. So hopefully that's going to be a fun little thing that we'll be able to have going on. Just a wee bit of technical background. Exotic has some interesting active ingredients. Not many ear ointments have gentamicin and miconazole, and hydrocortisone acetonate is a steroid that is unique to Virbac. This is the same steroid that's in Cortivance, so it's a high potency, very local effect, and it gets metabolized as it's absorbed through the skin. So by the time it gets to the blood vessels, there's very, very little actual steroid potency there. So it's very effective for local problems without causing any systemic effects. And it has some points of difference in its physical features as well. So it's got an airless pump. So it's not a straw in the bottom of that bottle there. It's a cellophane bag that, as it's pumped through, sucks up to the top, and therefore it works right way up, sideways, upside down, it doesn't matter. And this makes it really very, very good for squiggly dogs. 1 full pump of the nozzle at the top gives a 1 ml measured dose, and I know that Debbie's going to talk about appropriate dosing for different sizes of animals, but we feel that 1 ml covers a good wide range of dogs. So this is all about easier compliance for the owners. It's a once-a-day treatment. There's 10 doses in the bottle, so that's 5 days treatment in each ear, which should be sufficient for most cases of fairly uncomplicated otitis externa. And the cannula is very soft, and it's quite translucent as well, so you can see the ointment moving through it. So those are important physical features that give it some points of difference. Every now and then we have a client call me and complain that they can't get the stuff out, and they are inevitably trying to push the pump with their finger like a fly spray can, and it the spring in the top is actually quite tough. It needs to be because this is a thick ointment, and so what we say to them is it's much better to use your thumb rather than using your finger. So hold the bottle in your fist and press down with your thumb, and you'll find it easier to use it that way. And if you demonstrate that to your clients, hopefully your clients will find it easier to use this product as well. So we call this thumbs up for Exotic. So hopefully that'll make things a little bit easier. Oh yes, we don't need to go into this much detail about hydrocortisone acetonate, but it is a wonderful innovation. It's a unique product to Virbac. No other animal health company can use that. This is talking about how it gets metabolized through the skin. Starts off as the diester, which is starts as the diester, gets metabolized monoester, that's the high potency medication, and then gets further metabolized through to the 21-propionate, which has much less effect. So by the time it gets through to the bloodstream, it's not going to have any significant systemic effects. Epiotic's got several ingredients in it. It's a little bit more complicated. Lactic acid and salicylic acid and chloroxylenol, sometimes called paracloxymetazolinol or PCMX. It's also got propylene glycol as an emollient and decusate sodium as a surfactant, and those are important ingredients as well. The lactic acid and the salicylic acid form a complex that helps the propylene glycol to remove debris and crust and things like that. The chloroxylenol is an antimicrobial, and it's good for a variety of pathogens. The propylene glycol in itself is actually bacteriostatic, and decusate sodium is a filming agent that helps dry the ears out as well. So we don't want any maceration of the tissues. As far as physical differences, Epiotic has a nice screw top. The sales managers sometimes refer to this as the what is tomato sauce top, and that makes it much easier to close and to open and to use without much spillage. Right, don't want to spend too much time talking about my stuff. We're here to listen to Debbie. There we go. So, very good products to use together, which is the core behind the Better Together tagline that we're using for this focus. Very good. Please do feel free to email me, phone me, text me if you do have any other questions. All right, I'll hand on to Debbie. I'm sure we're all very keen to hear what she's got to say.
So I'll just open this up from my screen now.
Yes.
Or you're loading that from yours?
I'm handing over control to you, so you should get that authorization in a moment.
Okay.
There we go. Okay, I think it's all yours now. Debbie Simpson has control of my screen.
Very good. So I'll click on this now. Hopefully that will work. So is that how it should appear? Is that full screen how we want it?
Yes.
Okay. Perfect. So tonight we're going through treating otitis externa in dogs. I've packed quite a bit in here, so it's going to be hopefully lots of information that will be useful for all of you guys in practice. And thank you very much to Simon and to Virbac for providing the platform for the webinar, which is great. So otitis externa, we all see it every day, extremely common in dogs, and classically the factors are divided into predisposing, primary, and perpetuating factors. The predisposing ones being conformation, moisture, or a mass in the ear. Some breeds of dog, it's been shown, have more gland tissue in their ears, so they produce more wax. Dogs such as Cocker Spaniels have more hair follicles than other dogs. And conformation-wise, we've all come across Shar-Peis that have very narrow ear canals. Also, topically, the brachycephalic dogs at the moment, they have very narrow distal canals as it goes, the ear canal as it goes through the osseous canal to the tympanic membrane. That's normal for that to be quite narrow in brachycephalic dogs. And then there are the primary factors such as parasites, endocrine disorders, and hypersensitivity disorders. And then the perpetuating factors when they've already got otitis, such as bacterial and fungal infections, and sometimes contact sensitivities as well. The anatomy and physiology of the ear canal is obviously important, and so we've got the vertical canal, horizontal canal, and then at the end of the horizontal canal, the osseous canal as it passes through the bone, and then the tympanic membrane, and beyond that, the middle ear, where the nerves are for hearing and balance. I quite often do show owners models of the ear to explain to them where we're trying to get medication and get them to feel the ear canal so that they understand that they're trying to sort of milk the ear medication down the ear canal. It's useful for us if we're looking for neurological signs to try and work out if it's middle ear disease or external ear disease, because if dogs have neurological signs like nystagmus or a head tilt, or facial nerve involvement like the drooping eyelid or a lip on one side, then it means that either the middle ear or the area around the ear canal where the facial nerve passes can be involved. The nerves relevant to otitis are the facial nerve, cranial nerve 7, the vestibulocochlear nerve, number 8, or the sympathetic nerves passing through the middle ear as well, which is what gives you the signs of Horner's disease. So I think this diagram is right back from times at Massey with the first order, second order, and third order Horner's syndrome. And so if a dog has Horner's, then it is definitely possible that it could be third order and it could be due to middle ear lesions. The facial nerve crosses through the middle ear, leaving the skull just behind the external acoustic meatus. And if there is a middle ear problem, another sign of that which you might notice is that there's reduced tear production. The facial nerve is obviously also motor to the muscles of facial expression. So problems with the facial nerve can affect the muscles of the ears, eyelids, nose, cheeks, and lips. And that means that often they can't close their eyelids properly, especially the lower eyelid, because the upper eyelid also gets concurrent innervation from the oculomotor nerve. So if they can't close their eyes properly, or they have a paralyzed or a dropped ear and lip, it's all just clues that it could be a bit more than just external ear disease. So when you're trying to think about, is it otitis externa or media or both, why is that important? And that is important because it dictates the medication that you choose to use. And if there's middle ear involvement and the tympanic membrane could be missing, then that restricts your choice of medications that you can safely put down there. And so if there is any neurological deficits or facial deficits like the reduced tear production or the eye closing, then you might want to think about taking radiographs or using the video otoscope or doing further imaging like the CT or MRI. So it's just a good thing to think about at the beginning as to know whether it could be severe or not. One of the questions we had just before the webinar started is, would you use systemic antibiotics? If the middle ear is involved, then yes, you would. And if it's just the external ear, then no, you wouldn't. So imaging to look at the middle ear, the radiographs will show you the bulla, whether that's air-filled as it should be with a thin bony wall, or whether it looks like there's some soft tissue or fluid opacity in there. And CT or MRI is also really useful. So I don't know if people can see the little pencil moving, but on the this section, you can see the bulla with the white is the bone, and then you can see a soft tissue opacity in the left side, and the right side is air-filled as it should be. Sometimes it can be really hard to look down the ear canal. They can be too narrow, and some dogs are just really difficult to look at. A muzzle can take you so far, but obviously if the ear is so full of pus and debris that your speculum is just going to clog up as soon as you put it in there, there's not really a lot of point in trying to look when the dog is conscious. And even with sedation, if the ear is full of muck, it can be really hard to see. And in that case, it's hard to know if the eardrum is intact or not. So, and sometimes it can be very deceptive. So even if the dog is really good, and still it can be difficult to tell with a handheld otoscope if the eardrum is intact or not. And actually, even with the video otoscope, I've looked in ears and thought that I could see a white structure which looked like it was in about the right place. And when I touched it with the flushing tube, a lot of keratinous debris came out. So that actually was not the eardrum at all. So it can be really hard to tell. If the ear is full of pus, then you can use middle ear safe medication, which you know at least you're not going to do any harm with. And you can also use prednisone to try and decrease the white blood cells, which to help try and clear up the pus and decrease inflammation. We have a video otoscope at the skin vet, which is a great piece of equipment to be able to use. Ellie, my nurse, and I here have got a dog underneath all these blankets and things. And we're really lucky to have the video otoscope because it just makes visualization so much more clear. And Ellie is holding the camera, and I've got some biopsy forceps, which I can use down a working channel down the side of the camera, which is transmitting the image onto the screen. And you can just see the edge of the biopsy forceps going down there, and it gives us the luxury of being able to see what we're doing and work the biopsy forceps or the feeding tube for flushing at the same time, which is really good. Makes life much easier. So when you look down the ear, you ideally should see a nice, I mean, you never do, but you should ideally see a nice clean ear like this. So the image on the left is from a textbook, and on the right is from our video otoscope, which we're looking on a slight angle down the ear canal, but the eardrum is here, and the eardrum, which is you have the pars tensor and the pars flaccidum, is down here. And we tried to make this little video work, but it wouldn't quite work, showing that when you pulse water down there, you can see the eardrum moving backwards and forwards. That gives you confidence that it's definitely an intact eardrum by the way that it moves, and it's not just debris down the bottom of the ear canal. So with flushing the ears, we're looking for the normal movement of the eardrum as we pulse the water in and out. You can poke it lightly with the end of your feeding tube, being pretty careful to make sure that you're not causing any holes if you're not sure if what you're seeing on the surface is the eardrum or debris over the top of the eardrum. And by pulsing the fluid, you can see if any air bubbles come up from the middle ear, which would tell you if there's a tear in the eardrum. So it's a bit like a theatre curtain, that if there's a vertical tear, which is hard to see looking directly on, when the eardrum is moving, it becomes a lot more obvious. And you can see some little bubbles on the picture on the bottom left that are oozing up from a very small tear in the eardrum. The picture on the very left shows an eardrum that's missing, and because if fluid gets into the middle ear, it can go down the eustachian tube. If there's no eardrum, you tend to see fluid coming out the nostrils. So during ear flushes, we'll periodically check the nose and make sure that it's dry. So if a dog comes to you with an ear infection, having a look down the ear, if at all possible, is obviously important. I have heard stories of dogs having eardrops down their ear for 9 months at a time, and it turned out that there was a tumor down the ear canal. So you really need to know, is there a grass seed or a tumor or something which is preventing the ear disease getting better? You need to look to see if there's any neurological involvement, and we need to know if the eardrum is intact or not, because this does guide your choice of medication. So if the dog is too wriggly and or aggressive and you can't look down there, then sedation is definitely the way to go. So as we were talking about with the structure of the ear, this top part, the cystic looking part, is called the pars flaccidum, and that's a part which is flexible and can blow up like a bulldog throat or go back down according to the pressure in the middle ear. With anesthesia, it's often sticking out like that, and it can sometimes be mistaken for a cyst or an abnormal structure down the ear. The part that doesn't move is the drum type part, which is underneath. That's the pars tensor. And then the C-shaped bone that you can see through the pars tensor is the manubrium of the malleus, or the handle of the hammer, the little bone that connects all the bones of hearing into the inner ear. And you can orientate yourself by the small part of the C facing towards the nose. So the nose is to the left in this picture, and the longer part of the C is towards the tail. And this little fringe of hairs that you see down the bottom is normal. So if you are wanting to do a myringotomy, then the place to aim for is the caudoventral quadrant through the pars tensor and not through the pars flaccidum, and avoiding the bone, the little hammer bone. So what you should see when you look down an ear is a really nice eardrum like this. So we have the pars flaccidum at the top with sometimes little blood vessels running over the top. That's completely normal. And then the manubrium of the malleus, the C-shaped bone with the nose to the left and the tail to the right. And then this translucent drum-like, really firm structure, the pars tensor. And it is quite normal to see a few little hairs down there. This bit of wax is abnormal. What you actually see when you look in an ear is sometimes a clear ear canal right to the end where you see like a dark shape and you're not sure if it's a hole or if it's wax. And sometimes there's wax coating the ear canal right up to the top and you can't see anything down there at all. When you're looking end on to a plug of wax like this, you can't really tell how long it is or what's behind it, or what's happening to the eardrum. This one, when we pulled it out, turned out to be pretty long, occupying just about all of the horizontal ear canal. And this was an ear flusher that we did a little while ago, where we actually found a flea in the ear, which was quite exciting, which we managed to haul out with its mostly intact. So that's a photo taken on the desk of the flea with the video otoscope. So I always just discuss things with the owner. Not everyone can afford to do an ear flush or wants to have their dog sedated. So if you can't see an eardrum, I just offer to flush the ear. If owners just want to try medication first, then you can just explain to them what they might see if the eardrum is ruptured and if there's any neurological signs. And just say to them, don't keep giving the drops. If you see anything like that, stop the drops and let us know. But I think it is reasonable to try ear drops first without flushing to see if that can make a difference. And if you are suspicious about the status of the eardrum, then you can just use middle ear safe medications. So treating the otitis, once we've established that they do have otitis, cytology is absolutely critical. Just to use a cotton swab and take a sample from both the ears, roll it out gently on a slide. Some people do one slide for each ear, but I just keep the frosted part on the left and the left ear on the left and the right on the right. So that really helps me when I'm doing cytology if I'm trying to remember when I go back into the consult room. I think I was at the first one I looked at or the second that had all the yeast on, and if I always look at the left ear first, then it just sort of helps me to remember what I'm doing. And I just use normal Diff Quick to stain them, rinse them under the tap and blot them on paper. So it's very, very quick. I don't bother with any flaming or anything like that. And there is a little video which hopefully I will manage to make work, which I've taken. I took the video to show tape cytology and also ear swabs and talk a little bit about how you set up the microscope. So I'll click on it and see if I can make it work.
So we have our samples here from the ear swab and from the foot taping, and we've come out to the microscope. So the first thing to think about is how the microscope is set up. We start off on the 4 times objective lens, switch the light on, and make sure that the condenser light light is turned to maximum as well, because we're just looking at an ear swab and a tape prep. If we were looking for Demodex mites on a skin scraping and we had paraffin oil on the slide, we would want to have the light dimmed a bit. We would want to have the condenser partly closed, and we would want to put down the stage, which is a little button on the side, which puts the stage down, and that increases the contrast, so it makes it easier to see mites. But for normal slides, we have the stage up, the light on, and the condenser fully open. To stain the slides, we use just quick stain. We put the ear swab in the alcohol, which is stain 1, and then for the foot swab, we just peel the sellotape, the edge of the sellotape up, and you can just use a dropper bottle or a 1 ml syringe to go into the purple stain and put a drop of stain under the tape, and then spread that around a bit. We then give the ear slide a few dunks in stain 1 when the fixative, and then move over to stain 2, and just use a piece of paper to gently blot out the excess purple stain from the tape slide. That one's ready to stain 2 for a bit longer. Wipe any excess off and put that in stain 3. Give that a little bit of a swirl around, dunk it in and out a few times, and then we just rinse off the excess stain, wipe that on the side, rinse off the excess stain with plain water, and then we can just use a plain piece of paper to blot that. So blot it on the non-stained side first, and then just gently blot on the other side, turn it over and wipe the back, and now this one is ready to go as well.
Great, so hopefully that worked to just show that there's nothing really fancy about how I stain the slides up. It's really, really quick and easy, and you don't have to be excessively careful with it. All the stuff stays on there, even if you just run it under the tap and blot it on a piece of paper. So what we're looking for is sorry, going backwards and forwards on here. So we're looking for neutrophils to see whether there's any neutrophils there, and this one in the top left has got some intracellular cocci in there. Sometimes on samples, this is not from an ear, this is a cytology sample from the skin, but you can see in the top right there's a little fungal element in there. Sometimes we can see eosinophils or other cells. In the bottom right there's these peanut-shaped malassezia, and there's also this sort of bullet-shaped looking pollen. The middle picture has got all the purple in the background is smeared out neutrophils. That's the light mauve coloured stuff. And then the cocci is the little purple circles. And then bottom left is rods. So that pretty much covers most of what you're going to find in an ear. And then the next slide is whether we should take a culture or not. So to culture or not to culture is would we take an ear culture swab for culture and sensitivity for a first-time ear infection with mixed bacteria and yeast seen on cytology and no sign of otitis media? So I will see if I can find this poll. So create poll, cytology and culture, and I'll double click on this. And then you should be able to answer, hopefully now, whether you think yes or no to an answer to that question. So we've got about 50% of people answered so far. Up to about 60% of people now, so I'll just give it another few seconds for few more people to answer. That's about 2/3 of people now. And that's about that's most people, I think, that have answered the question now. So we'll end the voting, and about 85% of people have said no, they wouldn't take an ear culture swab, and 2% said yes, they would. So there we go. So I wouldn't take a culture swab for just a normal first-time ear infection if there's no evidence of middle ear disease, because most ear infections respond really well to empirical treatment. So it's just money that you probably don't need to spend. Cytology is definitely much more important. A culture tells you what grows well in the lab, but a cytology on the day tells you the proportion of what type of microorganism is down there. And if it's ear mites looking down the ear, will tell you the problem. If it's Demodex, a culture is not going to tell you that. Cytology tells you the important things, which is it bacterial, is it fungal, is it a mix of both, and are there neutrophils present or not? And then this is hopefully going to work as well. We'll go to video. Let's see if I can make this work. Open video, if this will work. So open presentation. I think it should be this one. It's quite loud, but I'm not sure if you can hear me as well, but it's just showing ear mites and what they look like close up. They're kind of revolting, but quite fascinating at the same time. Cool. Sometimes you find yourself staring at little white spots, wondering if they're going to move or not. So that's what ear mites look like on video anyway. The problems with ear cultures are that a sensitivity tells you whether the level of drug achieved in the blood is effective. That's what the culture and sensitivity is telling you, is if the dog takes an oral antibiotic, will that work against the bacteria in the ear? But we aren't trying to treat the bacteria or yeast with an oral medication usually. We're bombing the bacteria directly with an ear drop right on top of it. So the levels of medication achieved in the ear are far higher in the ear than in the blood. So most of the time a drug will work even if the sensitivity panel says it's resistant, for example, to enrofloxacin. If you put enrofloxacin on top of the bacteria, it will work. David Robson, who was one of my supervisors, did an abstract at the North American Veterinary Dermatology Forum in 2010, which was a prospective double-blinded study comparing the clinical response to empirically selected eardrops compared with the response predicted by culture and sensitivity. There were 16 dogs in his study with rods identified on cytology as the predominant microorganism down there, again on the day, from cytology on the day. And the topical treatment was selected on the basis of cytology and clinical exam only, not on culture. There were no systemic antibiotics used, and Pseudomonas in the end was isolated from all the cases, either pure or mixed in with other things. Of the dogs that were cultured, 10 out of 16 tested resistant to drops, but 8 out of the 10 of them responded anyway. The 2004 study by Graham Meisen-Rosser took 2 samples from the same ear, sent them to the same laboratory, and 20% grew different microorganisms. 20% same microorganisms but different sensitivities, and only 60% grew the same bugs with the same sensitivities. So it may not necessarily be reproducible, the results that you get from each ear culture. Why are neutrophils really important? Because they guide your choice of medication. So aminoglycosides like gentamicin, which is in Otimax and Exotic, don't work well if there are neutrophils present. So it's not a good choice if there are neutrophils there. So you might use an eardrop and think that it's not working, but it wouldn't be expected to work because that antibiotic is inactivated by organic debris. So if there are no neutrophils, then obviously Exotic or Otimax would be great treatments because they're convenient and really good for client compliance. But you're setting yourself up to fail if you use these drugs in an ear that's got pus in it. So what else can you tell from cytology? You can have a look and see if it looks like a pure growth of just one thing, if all the bacteria look the same. If they do look all exactly the same, there's a monomorphic population, it might be more pathogenic. But if there's a whole lot of mixed stuff down there, it's probably not just one pathogen, and it should respond well to treatment. So choosing an appropriate medication to put down the ears based on what's down there, and then recheck the ear in 2 weeks if it's a pretty uncomplicated one. If it's a really swollen, horrible, pussy ear, sometimes I'll recheck in 1 week. And unless there's a medical reason not to, prednisone is a really good idea if there's pus in the ear because it decreases the neutrophils and it decreases pain and swelling, and it makes it more likely the drops are going to get in there and more likely that they're going to work. Glucocorticoids are antipruritic and anti-inflammatory. They decrease secretions into the ear, and that's why glucocorticoids are in most eardrops. If there's only a neutrophilic inflammation, you could use just a glucocorticoid. And Cortivance or off-label or Alicon lotion, also off-label, can be quite useful to dry the ears and settle inflammation. They are both ototoxic if there's no eardrum, so you do need to be careful about that. Ear cleaners can be really good as well. In New Zealand, we don't have a whole lot of ceruminolytic agents, so epiotic can definitely be useful. You just need to be careful that the clients aren't squirting it in too often, as if the ears get too wet, they just get a bit soggy, and it's like having all those skin cells around the edge of a bath if the ear gets too wet. So it's a great product if it's not overused. Alpha ear cleaner is pretty good if the dog swims because it's a drying agent. It's not middle ear safe, so you do need to know the status of the eardrum. And it's just the same as humans using drying agents after swimming if they get swimmer's ear. This is the question that everyone was asking before the webinar started, is do we need systemic antibiotics? Not usually. There's not a very good penetration from taking a tablet to the stomach to the blood vessels and all the way back up to the ear canal again. So it's much better to use topicals, and then also you're not affecting the gut and the rest of the body. But the exception obviously would be if there's middle ear disease, because the middle ear is more vascular, and if there's any infection like a cellulitis outside the ear canal, then that would be a good indication for using an oral antibiotic. So the question's just popped up about what's too often for epiotic use. It's an individual thing with each dog, so I think it's just a good idea to keep an eye on it, and if it looks like there's a whole lot of grey soggy stuff down the bottom of the ear, then you need to back off on whatever you're putting down there, and if it's all looking great, then it's probably about right. So it's an individual thing. Systemic antifungals can definitely be a lot more useful than oral antibiotics because azoles are metabolized via the skin, so you can actually get quite high levels in ear canal skin. It's still not perfect, and it's not as good as a topical drop, but there are no commercial ear drops that you can use with an antifungal in them if there's no ear drum. Optimus can compound topical antifungals that are middle ear safe, but they're really expensive. So like a couple of $100 cost price. So I don't use them unless I absolutely have to. I think I've only ordered them twice. And you just obviously need to have the conversation with the owners about the possible liver toxicity of azoles like itraconazole. But they can be definitely more useful than oral antibiotics. Malaseb in the ears was something that used to be used a lot when there weren't all these other really good commercial ear drops. Malaseb's definitely a very good antifungal for skin, but for the ear it's too irritant, and it makes the ear very macerated and wet, and the dogs usually hate it. And usually if I see that the ear's bright red and the dog's not happy about it, it's definitely ototoxic. And there are just much better things to use these days. So definitely I would not put it down the ear, but for feet and skin, it's great. It's a great product that we use every day. And another question about Otaflush, it's a similar sort of thing. The difference with Otaflush is that it is middle ear safe. So you're not going to cause any damage, but you can overuse it and the ears can get too wet. We always show the owners how to put drops in. As Simon was mentioning, there are some studies that have been done on how much medication fits down an ear, and about 1 ml is great. You know, that's a normal average size Labrador ear. And if there's a bit much, then often there's infection on the pinna as well. So it's not a big deal if the eardrops come out the top and around the top of the ear canal. So we use a syringe because the owners can't tell how many drops are coming out. If the nozzle is stuck down the ear, you can't see the end of it. So we get them to pre-measure the amount that we want to put down there, and then not to touch the ear with the syringe, because these syringes are obviously not as flexible as the exotic soft tip. And if they stuff the syringe down there, it can cause ulceration and hurt the dog, which is one advantage of the exotic, that it is soft and flexible. So volumes of drops on an average ear, just use your judgment. It's usually about 0.4 to 0.5 mils for a cat or a little dog or a really tiny ear, and a medium-sized dog about 3/4 of a mil, and about 1 mil for a Labrador, and more for a Great Dane. We usually don't go much above 1 mil because it's 1 mil syringes fit inside the opening of most eardrop bottles, so it's just convenient to use 1 mil. But if you've got a really huge ear, you might need to put more in. And always recheck them. Ask them if they've got medication left. It's amazing. I've definitely had referrals where the vet's done everything right. They've diagnosed exactly what's down the ear. They've dispensed the appropriate ear drops, and the dog's ear hasn't got better. And I've seen the client, and they've brought the drops in, and they didn't give them. So that's why it didn't get better. They thought that particular client thought that the ear was making a funny noise when they put the drops in, so they didn't like it. And so they got referred for the ear disease, but really, if they'd just done what their vet said, it would have got better. So at the recheck, ask them if they've got any drops left, and if they have, then that's not right usually, and take another cytology sample, see how the dog's going. Usually when we see a really nasty ear, we will recheck it in a week, and if it's fine, we'll recheck it 2 weeks after that, and if it's fine, we'll recheck it 4 to 6 weeks after that. So we just space out the interval of rechecking depending on how they're going. And always tell the owners they can come back earlier than the scheduled recheck if they've got a problem. So if the ear disease comes back after you've treated it appropriate the first time, then that's when you need to think a bit harder about why it happened in the first place. You need to think, did the owner put the drops in? We get people to show us how they do it, and you have to be quite reassuring, because they feel quite like under pressure, and so just be nice to them and reassure them that they're doing it right, and it gives you a good chance to see what's actually happening at home, and so that they're not doing anything weird. So primary causes, as we talked about, are those ones that can cause disease in a normal ear, like parasites, like the ear mites that we saw, or endocrine disease, or hypersensitivity disorders. So as I mentioned, one dog that I saw in a referral hospital had a tumor down there, so you always have to look. And swimming or grooming are extremely common reasons for getting ear disease. So we always tell people when they're washing their dog, don't get the ears wet. And if their ears are plucked at the groomer, I often say give a prednisone the day of grooming if there's no reason not to. And then think about allergies like food or atopy. So dosages for different sizes, it depends on the ear drops. So exotic is once a day. There was just a question there about dosages. So it depends on the drop. Some drops like Otimax are once a day, exotic is once a day. Other ear drops are twice a day, Orizon's once a day, Suralan's twice a day. So it just depends on the product that you're using. Anatomy and physiology, definitely with chronic disease, the ears can physically change. They can actually turn into bone. I've seen an ear that the surgeons did a TICA on and came out and banged it on the table, and it sounded like an actual bone. Really, really hard. There's no way that you're going to medically manage to fix that ear. So you're on a losing streak if the ears are really narrow and calcified and hard. There are sebaceous glands at the entrance to the ear and in the vertical canal, and then deeper in the dermis and further down next to the eardrum, there are more apocrine or ceruminous glands. In the healthy ear, the wax is made by the sebaceous glands, so the ones higher up, and in the diseased ear, more wax is made by ceruminous glands. The ceruminous glands wax is more acidic to try and kill off any bacteria that are dead. So primary causes are those that can start an ear infection by themselves. If you can identify and treat them, you might fix the ear disease. And the common ones are food and atopy, grass seeds and fleas, as we saw, not that that's a common thing, but foreign bodies and infectious disease like mites, ticks, demodex, aspergillus, ringworm. There are more unusual primary causes, I mean, they're pretty rare, but if you're still trying to scratching your head and the obvious ones have been ruled out, then there are other things like zinc-responsive dermatosis or hypothyroidism, drug reactions and things like that. Always think about the breed. So swimming, common cause, hypothyroidism. I wouldn't say it's an extremely common cause, but it's possible. And just always look at the rest of the dog. I've had plenty of referrals for dogs for ear disease that the owner told me they had no other signs of skin disease at all. And when I looked at their feet, they looked like the foot in the picture, and the owners just had never noticed. So a case study, little Milo came in to see us, a 5-year-old male neutered spoodle, and he was really, really head shy and hid under the chair and had to be dragged in like a little mop across the reception floor. And it had been going on for a few years, and treatment fixed the problem, but then it just came back again really quickly. He was one of those cases that I offered them, if you want to try drops and see how they go, but they'd been doing that already, so they just wanted to have an anesthetic so that we could clean the ears and have a look. So I think this actually is him under all the blankets. And his ears were really red. You can see how sore they look. They were absolutely packed full of stuff, and there were ulcers down the sides of the ear canal. The little green tube you can see is the flexible 5 French feeding tube that we used on the side of the video otoscope, and we try and sneak that past the debris and gently flush it up to get it out of the ear. In his ear flush, both his eardrums were intact, which was a good thing to know. The eardrums moved normally, didn't see any fluid coming out the nose, no air bubbles coming up, and that means we can use whatever we like to treat his ear disease. So he had rods, yeast, and neutrophils in his right ear, which was the worst one, and only yeast in the left ear, and that's why his right ear was so much more ulcerated and inflamed. Rods and neutrophils often go together and cause a much more painful ear than just a yeast infection. So we use just Orizon for his left ear. I just chose Orizon because it's easier to use the same thing in both ears so that owners don't get confused. Lots of owners can't work out left and right, so they keep asking you, is it when I face the dog or when I'm facing the same way as the dog? So just try and make it simple for them. And the Otaflash followed by Orizon is what I chose for the right ear because there were rods in the right ear. Rods can be really hard to treat, and the Triz-EDTA or the Otaflash pre-treats the rods and it makes it easier to kill them off. it changes the pH in the ear and makes it more alkaline, and aminoglycosides and fluoroquinolones are more effective at an alkaline pH. The tris-EDTA or the odoflash chelates metals, which are part of the bacterial cell membrane, and Pseudomonas uses a calcium-mediated pump to pump out the drugs. That's how it protects itself. So tris-EDTA blocks this pump, and it means that your medicated drops can actually get into the bacteria and kill it off. So something like tris or odoflash will make a big difference in your MIC of the Pseudomonas. Systemic prednisolone to reduce inflammation and try and get rid of those neutrophils and open up the ear canal. Because of the neutrophils, you wouldn't choose Odomax, wouldn't choose Exotic. Gentamicin is a fantastic drug if there's no neutrophils. So it's just choosing the right thing for the right problem. So Milo, a couple of weeks later, much happier and more comfortable. When the ear drops finished, he started shaking his head again. He swam in the Oraki Basin, which is a cesspit of bacteria that lots of dogs get skin and ear disease from. Unfortunately, our water quality in New Zealand is not quite as good as it could be. And so I said, no swimming, don't get his ears wet at the groomer, and gave him some more prednisone and ear drops. So so once you've treated, you definitely need to recheck ears, especially if it's been an ongoing problem. I'll usually back off slowly and keep checking them to make sure that things aren't relapsing. So I decreased the prednisone to every other day, kept them out of the Oraki Basin, and decreased the drops to twice a week, and then got them to come back in a month. Month later, they've been doing everything that they were supposed to be doing. The right ear started to build up wax again. It had been chronically irritated. You remember that was the worst ear, so the wax glands were a lot more active in that ear. And the left ear was fine, but the right ear had a few bacteria starting to come back. So then we started to think about, could there be another reason other than chronic inflammation that's triggering the problem? And at that point, the owners remembered that he was a bit prone to GI signs and he had a sensitive stomach. So I offered them if they wanted to do a diet trial, and they did. So they started on the Royal Canin analogenic. And finally, that was the key to fixing the ears. So now we've got another poll question, which is what percentage of food allergic dogs have otitis as their only clinical sign, so no other skin signs at all. And let's see if I can find that one. Okay, cool. So there's the question. Percentage of food allergic dogs having otitis as their only clinical sign with no other skin signs. Got about 50% of people answered so far. Got about 70% of people answered now. So I'll give it a couple more seconds. And then end the voting in a second or two. Cool. So that's most people now. So so I'll stop the voting, and the most popular answer was for 20 to 25%, which is correct. So 53% of people thought it was 20 to 25%, which is right. And the second most common answer with 17% was that 10% of dogs have otitis as their only clinical sign. So it can be surprisingly common. So allergy in ears, bilateral ear pruritus and otitis occurs in about 80% of food allergic dogs that also have other skin signs as well. But it can, and this is what surprises people, the owners especially, that they're like, how can itchy ears be the only sign that he's food allergic? But it can. It makes it incredibly difficult to monitor a food trial if ears are the only sign. It's way easier if they're licking their feet as well or getting rashes or something that the owner can actually see. But you can only do your best at trying to change the diet and monitor them. Atopic dogs also have otitis very, very commonly, and it can be the only sign again in about 10 to 20% of atopic dogs. The secondary and perpetuating causes don't cause disease all on their own, but they perpetuate it. Examples include bacteria, fungal or yeast infections, otitis media, hyperplasia of the canal. You can imagine why all those things would make it hard for the ear problem to clear up. Very common bacteria are staph, that's probably most of the ones that we see, and then strep, Pseudomonas, Proteus, and sometimes Corynebacterium as well. Malassezia is extremely common as well. You're allowed to see a few malassezia in normal ears, and about 1 per 500 times field is acceptable, and more than that, it's obviously a spectrum, but if you see more than that, then it might be worth treating, particularly if the dog is showing signs of irritation. Aspergillus and dermatophytes, it depends on the rest of the animal as well, there are instances of Aspergillus otitis, but they're pretty uncommon compared to yeast. And if they grow on a culture, again, you have that question: is it a contaminant? Is it important? Is that the main problem? If you've taken cytology, you'll have an idea of what other things are down there. There is this paper in VetDerm about otomycosis caused by Aspergillus in a dog, and there were no other pathogens down the ear on cytology, and it did respond to treatment, so that seemed to be the main cause of the problem. So I've whizzed through things pretty fast, but to sort of summarize a bit, maximizing your chances of success, having a really good look, trying to sedate or muzzle if it's hard to look straight up, definitely doing cytology and basing your medication choice on what you see on cytology. Consider pain relief, so prednisone for its anti-inflammatory qualities, or codeine or temgesic if you think they need that. And if it doesn't clear up, or if it comes back really quickly, then think about other causes that might just be causing it to come back all the time. And if it's hard to see, and it would benefit from a video otoscope or from some more imaging, then you could refer it. So not every single ear infection is treatable, and I think managing owner expectations is incredibly important. So if the dog turns up with an ear like that, and when you palpate it, it feels like, like the canal has turned to bone already, then you're not going to be able to manage that ear medically. So you might be able to get rid of the surface bit of infection and make them feel better for a while. But if you do your best, obviously you'll try with drops if they don't want to do surgery, but always mention it, and mention to them that it's going to be virtually impossible to fix it if that's what you think, because some ears are just not fixable. So I'll always try. If I see a really, really swollen ear that looks like it might be more puffy and edematous and inflamed than bone, then I'll give prednisone at 1 milligram per kilogram for a week, and I'll give it my best shot. And if they come back in a week and it looks exactly the same, then I'll say to the owners, I don't think I'm going to be able to fix this ear, and surgery might be the best option for the dog. Ruptured eardrums can heal. That's another common question that people ask, and they can heal within a week if there's no infection down there and the ear's clean. So is a ruptured eardrum a reason for surgery? No, it's not. You just need to be careful what you put down there. And then this is something which people might find useful about what drops are middle ear safe. So if you need something for yeast, then you can ask Optimus to make you ketoconazole with squalene. It's very expensive though. You can make yourself in clinic Bactriol and saline or Methopt drops. So Methopt is just the eye drops. And the Optimus type 1, we might use something like ketoconazole, enrofloxacin, and dexamethasone, or this is all off-label, of course, for the things you make yourself. You can use dexamethasone Baytril and saline, or dexamethasone Baytril and methopt. And if they don't have the right concentration of Baytril, I think in New Zealand it's only 2.5 or 10%, then you know, there's no hard and fast figures. It's just sort of adjust the recipe a little bit. So, and that is, I think we've got to the end. I was trying not to take everyone's evening up too much because I knew I squashed a lot in there.
Thank you very much, Debbie. That was absolutely fantastic. Everyone really enjoys your presentations, and that certainly was very information dense. This is a complex problem that we see so very commonly in clinical practice. So your insight is so very helpful. We'll get the quiz going, and then while that's doing its thing, we'll allow people to answer some questions. All right. Okay, so hopefully people can see that. Just 5 questions. Yep, people are whizzing through it. So the first question that was asked, Laura asked, can you give us an idea of how much it would cost to set up your own video otoscopy system from scratch?
We use the telepack, the Storz telepack, and I think that was about $30,000 to buy new, and you can use it for other things other than ears. We don't, but I think there's other bits that you can kind of stick on it. So for us to just buy it for ears, buying just the screen and the camera and some instruments and things was about $30,000.
All right. I wanted to know if pus is still going to be still going to inactivate gentamicin if the ears had a good cleaning prior to treatment. Is that still going to be a problem?
If the ears, sorry, what was the question? If the ears are,
if you've got an ear with a lot of pus, you've got neutrophils on the swab, and you give it a good clean out prior to every treatment, is gentamicin still going to be inactivated?
I mean, it's just hard to get rid of all the pus. So using prednisone or cleaning is definitely going to help. But usually I'd use a fluoroquinolone because they work. So I would use something that's got a fluoroquinolone in it.
Right.
And then, so I would save my my drops for that are gentamicin based for things that don't have neutrophils in, because they just come back so quickly. You know, as soon as you clean them out, they're back again.
Yes, fair enough. And you'd answered about how often cleaning with Epiotic is too often, but I mean, were you talking about the routine maintenance cleaning in that situation, or was this during
there's
treatment?
different uses. There are different uses of it. So there are definitely studies that have shown that ear infections have been cleared up with just using Epiotic on a daily basis for a couple of weeks. And then it's also used on a sort of once weekly or a kind of as needed type basis to just sort of try and tip the balance in your favor by clearing out debris and changing the, you know, the acids in the ear. So there are different ways that you can use it.
Good. And regarding the case study with cute little Milo, Michaela asked, how soon after cleaning with Otoflush did you put the ures on, and did you have a 30-minute wait in between, or?
No, just straight away.
Just straight away. Excellent. And Ruby asked, were you worried about cross-contamination? Yes, because there were different organisms in each ear for Milo, but you're using the same ointment in both sides.
But we're using syringes, so 2 different syringes, same bottle.
Perfect. Okay, very good. Reese asked regarding Milo, did you say that you tapered the treatment down and got to twice weekly treatment with medicated ointment?
Yeah, I do often do that. Go from daily perhaps to every other day, or to twice a week, or sometimes to once a week. And sometimes I'll use medicated drops, like you could use Exotic or Orizon or other medicated drops, or sometimes I'll use Cortivance or Alicon off-label. If we're trying to just settle inflammation and itch and redness, rather than actually if there's any yeast or bacteria down there.
Good. Okay, well that kind of touches on Tareen's question. So she was concerned about the twice weekly treatment with medicated ointment. She's worried, she wanted to know if you are concerned about the development of antibiotic resistance when you're using medicated ointment twice weekly.
So yeah, it can be a concern, and if that's a worry, then I'll go for just steroid drops if the main problem is inflammation. But if there's kind of 1 or 2 yeast around, then it does seem to work quite well. Just use it once or twice a week, because it is a topical, not a systemic. So you're achieving very high, concentration of antibiotic in the ear, and you should hopefully be killing everything off and not leaving little resistant populations.
Yeah. Good. George asked how long the dexbacterial saline lasts for after you've made it up.
I usually give them about 2 weeks worth, so I just sort of measure it out of how much I want to give them, and I don't keep it in the fridge. Tell them to keep it in the fridge, make it about 2 weeks at a time, and then see them back.
Do you put an expiry date on the bottle?
No. I just, because I know I'm going to be seeing them, so
yeah.
I just say give it twice a day for 14 days, and then stop.
Yeah. Julie asks for middle ear safe drops. What container do you dispense them in?
We just use a pill bottle, like a plastic pill bottle.
Good. Jolene, yes, absolutely. This is being recorded, and it should be available on the Virbac Learning Centre in about a week or so. But everyone who's attended today and everyone who was registered will get a link to that video, and the quiz is going to be at the end of the video as well, so you get your full CPD points for that as well. So Chelsea asks, clinically treating for atopy/allergies has helped clear up otitis in many of my patients, specifically cytopoint. Is this just a stabilization of the skin/immunity, or is this due to something else that I'm not attributing to the MC antibiotic use? I'm not quite sure what she means by MC. Do you get that question, Debbie?
So definitely controlling the primary disease like allergy or food, atopy or food allergy helps, because you're reducing inflammation in the skin and you're normalizing the skin. So there's less inflammation going on. So I think that's how it works. If the atopic skin or skin that's involved in allergies is different to normal skin, and if you can treat infection and treat the disease, then it does begin to return to a more normal type of skin, which is less prone to infection.
Excellent. Reese asked, I find that a lot of dogs can have ongoing otitis externa, brown discharge and smelly, but the owner says they aren't itching, and I find that it would be bad stewardship to use topical antibiotics, antifungals, if they are unlikely to comply, and the dog isn't showing clinical signs such as itching and pain. Should they be treated whenever there is a smell or moderate discharge present?
I know, or some owners, honestly, I remember my supervisor saying once that they wouldn't notice if the dog was on fire, and it's amazing that they say, the dog doesn't have a problem with its ears, but you take a swab out of it and their back ear starts thumping like thumper, and they start groaning, and, or you find blood on it, and so I point out the leg and I say to the owner, oh, they're probably doing that because they're itchy, or I say, is it itchy? And they're like, no, but he rubs his face on the floor all the time. And so sometimes people just don't understand that their dog actually has a problem, which is a bit disturbing. So, but he's right. If the owners don't perceive it to be a problem, it can be a real uphill struggle to try and get them to treat something that they don't think is a problem. like that owner with the feet, when I pointed out that their feet were, oozing and had, no fur and were bright red and bloody, and they were like, oh, I haven't noticed that before. And they had yeast on them and treated the yeast, and then the next time they came back, we turned the feet over and just showing them the difference. Sometimes I take pictures and I showed them the feet 2 weeks ago and the feet today, and they're like, oh, yep, no, I can see that that's a difference. But I still never noticed them chewing them. So, I mean, what can you do? You can only do your best, I think.
Janine asks, how often have you seen unsafe ototoxic ear meds causing otitis media / neurological signs when unknown eardrum rupture? We were scared that this was big at Massey, but we've since been told it's actually rare.
I wouldn't say it's that rare, and I definitely have seen it. I've seen it with Suralen and other drops, and I've seen dogs go deaf from it and develop neurological signs, and we've definitely been referred very, very cranky owners that are talking legal action. And obviously you try and look after your vets and talk people down from that kind of thing and say it can be hard to see, but no, I've definitely seen it quite a few times, and it's just a bit hard to defend, like why you would use a medication if the eardrum is not intact. I think it's fair enough, as I said, to use drops if you can't see, and to tell the owners that you can't see, and it's their choice if they want to flush or try drops, because not everyone can afford to do the flush, or there might be a medical reason why you don't want to anesthetize the dog. But you just have to cover your butt and explain the risks, and if that's what they choose to do, tell them what to watch out for and to stop if they see any neurological signs. It definitely happens. It's not a myth.
Yeah. And Chelsea, thank you very much. Monoclonal antibodies was what MCAB meant. I'm sorry, I didn't know that one. Genevieve asks, would you use oral preds for ear plucking once off ?
Yeah, I would. Yep.
That sounds good. I mean, I can think of other situations where we know there's going to be an inflammatory response, and people have pred on hand for that to keep things under control. Laurie asks, if ear medications can get through hairs, is hair plucking necessary or more irritating to the ear canal?
Yeah, that's a good question, and I gave a talk to some groomers last year, and just asked their opinion about what they do, and do they do it in all dogs with hairy ears, or because they're the ones that do it most of the time, and their opinion was that some dogs it's really easy to pull hair out of, like poodles that can have quite hairy ears, and the dogs tolerate it quite well, and some dogs like schnauzers and things, you can like take a good grip and the dog will absolutely scream because it doesn't come out very easily. So I think every dog is different, and if the dog has a really, really hairy, like almost completely clogged up ear canal that you can't get eardrops through, then pulling that hair out is a good idea. And if it's just 1 or 2 hairs that aren't really causing a problem and medication can get past it, and it's a breed where it's not going to come out easily, I'd leave it alone. So.
Good, that's helpful, thank you. Nome asked, can you explain a dog that has a painful or irritated ears, but the ear canals look absolutely fine on an otoscopic exam? Is this atopic disease?
It could be, yeah, absolutely. So we had a nurse in Melbourne that had a dog that was head shaking all the time, and the ears looked pretty normal, but she really wanted us to anesthetize the dog, use the otoscope, make sure that have a really good look, because it had been bothering the dog for ages. And when we looked down there was literally 1 hair on 1 eardrum that we pulled out with the biopsy forceps, thinking, well, I'm sure that's not the cause of the problem, but that fixed the problem. So I think some dogs are just really, it must be really annoying having just 1 hair tickling your ear. And then also I think it is a feature of allergic disease that sometimes the ears are itchy, just like with hay fever, your eyes are itchy, but they might look normal, but you can feel itch, before they start rubbing and making everything red.
Good. And Janine's talking about one of my favourite cocktails, dexpatral mixed with trizzy or Otoflush instead of saline. So Otoflush wasn't around when I was in clinical practice, but we'd get trizzy made up at the local pharmacy and would dispense some dexpatral trizzy as our one of our good mixtures. So what do you think of that, Debbie? Oh, you're making a sad face.
I don't. So I don't mix it in together, but I will use them one after the other. So I'll put the triz in first, and then put the dexpatral in second. So
Yes.
you know, speaking to the Otoflush people, they're like, there's no stability or, you know, information available on that. But then I guess with mixing it with methox, you know, I'm not sure how many studies there are on that either. So, but they definitely, I think, don't really like the idea of putting it in there, but it's fine to put it in afterwards.
Chelsea's asked if anyone knows how to get hold of Tresiderm.
I don't know that you can get it here. I mean, probably you could get it on the internet, I would imagine. But I don't think you can officially get it. Not that I know of, anyway. I don't know if anyone else knows if you anything different.
It's a restricted veterinary medicine, isn't it?
Yeah, but you know what people are like. There's ways and means of, you know, getting things.
There would be actually be a legal way to do this. I mean, the classic. So we end up in a situation like this where people want the 9.4 milligram of Suprelorin, which we don't distribute in New Zealand anymore because there just weren't enough people who needed or used it. So we only distribute the 4.7 at the moment. But the zoos love the 9.4. They put it in their big cats. And so we help them apply for a special import license, and then they can order it directly from wholesalers in Australia. And that is completely legal and above board, but it needs a new application to MPI for each individual animal. So it's an expensive process, but you know, if there's a medication that you definitely need for a particular patient that is available in Australia or the States or Britain or Canada, then that can be done completely above board. And so if people wanted to email me if they've got a situation like that, I can help you through that process, even if it's not a Virbac product, because we've had to do it a few times for Virbac things that we've been forced to discontinue. Yes, so another question. When you flush the ear canal, do you normally see the ear canal or look more for the bubble? The water's always in the way. Oh, yes, when I'm cleaning ears, there's dirty water in the bottom that's hard to work with. Do you have some tips for that?
Oh, it's just really, really hard. You know, I'm just spoiled that I've got the otoscope, so I have actually never tried to flush an ear without the video otoscope because I went straight into an internship and then straight into a specialty. So I think it would be really hard. And people have asked me before, how would you do it? And I'm like, I don't know. I think it's like, it seems really impossible. It just seems really hard to do because you can't look, and yeah, the vision is hard when you don't have the otoscope. Yeah.
Janine says she's got a dog that shakes his head and paws at his ears every time he barks, but his ear canals look perfect. What are your thoughts?
I know, and I've had a referral of a dog like this as well, and the owner said that his ears seems to distress him when it's windy and when he barks. So and I puzzled over this, and I thought, could it be a problem with the TMJ, or you know, is there? And I tried opening his mouth because I thought, is it the actual opening his mouth when he's barking that's doing it? But that all seemed quite normal. And I flushed his ears, and they all looked quite normal. And then he got some other skin signs, and we've started him on immunotherapy now, and his ears seem to be quite good. But what that has to do with barking, I don't know. Like, I've puzzled over a very similar sort of question to that before. I thought, I'm not sure what the link of that is.
Suzanne's asking about the suction units that humans have. that they use in human ears. Do you think that they'd be suitable? I don't think they'd be long enough.
I don't think you can see, can you? Like with those little suction things.
I don't think so, no.
Yeah. So, and sometimes people you just use those bulb syringes, but yeah, I think well, you just can't see what you're doing. So who knows? There could be anything down
Yeah.
there. Unless you can see what you're doing, then you're operating kind of blind. Yeah.
Yeah. But I mean, for suction, a feeding tube and a syringe usually works
Yeah.
pretty well. But
Yeah.
correct me if I'm wrong, but don't do it blind, or you'll end up stabbing through the eardrum.
Oh, it's so easy to poke through the eardrum. And yeah, I've seen the suction, like some people use the video otoscope with suction, but I hate it. It's just like all complicated. And a syringe is good. You can poke things with it. And you know, I just feel like more in control with holding like just a syringe and a feeding tube because it's a manual. I can control how much pressure goes on and I can use the end of the tube to move stuff. It's just, I guess, a personal preference.
Good. So I think we should probably close the quiz. We've had 79 people finish it, and we've got an average score of 77%, so that's pretty good. And Finley asked about what material you use to flush with. Normal water, saline, sterile saline. What do you use?
We use those bottles of saline that you use for, you know, irrigation, saline for irrigation, those bottles that are like a litre or 500 mils.
And Michaela's asked, human otitis externa can cause severe tinnitus with loud noises. Oh, she was saying about the dogs barking, maybe that's why.
Yeah. So if they've got otitis, but I mean, we're talking about a dog that I think that didn't seem to have any otitis. So tinnitus, I guess, yeah, how would you know? It could be incredibly loud noise, like because the dog I saw, they were worried about wind as well. But yeah, I wasn't sure if the owner, like, I wasn't sure if I didn't know what that was all about, to be honest. There was nothing that made any logical sense. But yeah, there are some weird ear things that can happen sometimes that I've, you know, as well as seen with humans where they've got like just a thinning of the cochlear, you know, wall, which they diagnosed on goodness knows what MRI that was causing a problem for one lady on some kind of medical program. And I thought, how on earth do you diagnose that? Yeah. It's pretty.
Dan asked about using a Tomcat catheter for the suction. What do you think about that?
Well, we use a feeding tube just because it fits down the side of the camera. So we just use a little 5 French tube because it's quite nice and flexible. And then we'll use a rigid tube if we're doing a myringotomy. So I guess it depends, yeah, if you want a rigid catheter or a soft catheter. But we just use what fits down the side of our camera. Basically, that's how we chose that.
Yeah. So, I mean, I have tried to use Tomcat catheters before, but I found they just kept on getting blocked and they're too stiff.
Yeah.
But that's personal
So
opinion.
if you want a stiff one to like stick through the eardrum, then we do that. But otherwise, yeah, you're trying to be really gentle, and you don't want anything that's going to traumatize the ear canal or scrape it or go through the eardrum. Yeah.
Okay. Well, thank you so much, Debbie. That was absolutely wonderful. Very, very helpful and informative. I think we're all feeling a bit smarter because of this. Type of video otoscope. Kristen wants to know about what brand you would recommend.
For video otoscope, well, we use the Telepac Vet X, which is really good. That we got that I bought here in New Zealand from what are they called? Medipac, I think their name is. Adam Neal, and they were really helpful. And in Melbourne, we used a MedRx scope, but I prefer the Telepac Vet X. It's really good.
Good, thank you. Okay, and thank you very much to all of our participants for taking an hour and a half out of your evenings. We really appreciate your attendance. We'll have this video available soon. We'll hopefully have it up within a week, and I'll hopefully have your CPD certificates out to you within a week as well. And do look out for our upcoming webinars. We've got a few planned, and we'll get the advertisements out